Okay, in this chapter we're going to cover the urinary system, and I'm going to break this up into two parts. We'll do the first part is more anatomy and some terms, and then we'll break it up into the pathological conditions second. Okay, so the first thing we'll look at is the kidneys, and so let's kind of do an overview here of the urinary system. So the primary function of the urinary system is to remove toxic waste products from the blood, okay? And with that movement or with that filtration, we actually eliminate those products within the urine, okay? There's a couple of hormones that are secreted by the kidney. In the endocrine system, we found out how many different kinds of glands that we have in the body. And we have three other glands that also secrete hormones. The kidney is one of them. The stomach and the heart also secrete some hormones, but they aren't technically listed as part of the endocrine system. So one of the hormones that the kidney secretes is called erythropoietin. You'll see it acronymed EPO, and there are some synthetic versions of erythropoietin that can help basically stimulate red blood cell production within the bone marrow. And so there are certain conditions where people might have low erythropoietin levels, and so those synthetic medications can actually stimulate red blood cell production within the bone marrow when people have problems with this hormone. But essentially the kidneys can secrete it, and when it senses that there's anemia or a lack of blood cells, red blood cells within the system, this hormone will be released, and that will stimulate the red bone marrow within the bone to actually make more red blood cells. Another hormone that the kidneys produce is something called renin, and renin is a hormone that aids in raising blood pressure. And so if the kidney senses that the blood pressure is dropping for whatever reason, it could be blood loss, it could be a number of other things, it will cause the secretion of renin, which will then cause a temporary increase in blood pressure. Some of our antihypertensive medications actually involve the blockage of renin being secreted, which can then secondarily act to lower blood pressure via medication. So let's start off by looking at the structures in the urinary system. The kidneys themselves, we have two of them. They are bean-shaped organs. They're kind of located on either side of the vertebral column. Sometimes you hear it called paravertebral. They are in the upper back portion of the upper abdominal cavity, and they are considered to be retroperitoneal. And what that means is they are actually behind that floppy membrane that covers the intestines and most of the abdominal organs, and so they are located behind that peritoneum. So they are considered retroperitoneal. We have three different layers of the kidney. The very outer layer is called the cortex, and that's generally what cortex means, is outer. Within this cortex, or within the cortex of both kidneys, there are millions of microscopic units called nephrons. And the nephrons are the actual filtration process that are the area, or the actual functional unit that does the filtration process within the kidney. That filtration process is made up of two components. The first one is the glomerulus, and the glomerulus is a small, very tiny, coiled and intertwined ball of capillaries that allow movement of some components through that filtration process, while others are reabsorbed. Larger things like white blood cells and red blood cells are not siphoned through, are not allowed to get through if everything is healthy. And it only allows smaller particles like hydrogen ions, potassium and sodium ions, bicarb. Sugar is actually small enough to get through as well, but we'll find out later that sugar is reabsorbed farther along in the process. Then we have an area that surrounds the glomerulus called Bowman's capsule. Sometimes you'll see it referred as the renal capsule. It has a double-walled membrane, and it's kind of cup-like. It kind of surrounds the glomerulus like a C-shaped cup, and that is the start of the tubular system that actually leads to the filtration, or leads to the removal and addition of certain components. So the filtration process is made up of these two components, the glomerulus and Bowman's capsule. And then from that point, that Bowman's capsule then opens up into a renal tubular system. And there are different segments of the renal tubular system, and they have different names depending on the position that they lie. This tubular system is an area where we can have secretion and reabsorption of different solutes. Once again, water, sugar, glucose, potassium, sodium, hydrogen ions can all either be reabsorbed or secreted depending on what the body needs. Okay, the tubular system is intertwined with another set of capillaries called the peritubular capillaries, and so those components, those solutes and water can be absorbed and secreted depending on the need of the body. Then we travel in from the cortex, so that's the outer layer. Then we hit sort of the middle layer and the inner layer of the kidney. And so the middle layer is called the medulla, and that consists of some triangular tissue, triangular shaped tissues that involve the renal pyramids. Okay, and that's where we have our tubular system. Okay, from that tubular system, we then open up into a couple of small cup-like collection areas called calyces. And we have some smaller ones called minor calyces. Those minor calyces then opened up into larger cups called major calyces, which then opens up into the largest cup, which is in the very inner part of the kidney called the renal pelvis. And so it's basically just a duct or collection system. So as the kidneys filter and pull out the glomerular filtrate, there's a place for this area to go. Okay. Now that renal pelvis that's there is actually the very upper portion of the next structure that we come across called the ureter. And the ureter is a muscular tube. We have one ureter coming out of each kidney, and the urine is propelled through that tube via a motion called peristalsis. Okay, urine is constantly being formed. We always have those millions of glomeruli are always, or filtration process that is made up of the glomerulus and Bowman's capsule are always forming urine. It's a constant process. So that urine has to be moved from the kidney into the next structures. So the ureter is what carries the urine from the kidney down to the bladder. Okay. So the next structure is the bladder, and the bladder is basically a holding sac. It's muscular. It's hollow, and it's the holding sac for urine. It's constantly made in the kidney, but we only urinate 6, 7, 8 times a day, depending on how much water we drink or possibly how much alcohol is drank. Different things can affect how much you urinate, but overall it's about 6 to 8 times a day. Okay. The bladder itself is anatomically positioned between the symphysis pubis and the rectum in males, and is between the symphysis pubis and the uterus in females. Okay, it is termed or coined the temporary reservoir. So if you were to see that, that would be indicating the bladder. It's normally kind of an inverted triangle or pyramid when it's empty, but it can become spherical or round when it's full. So from the bladder, which is our holding spot or our temporary reservoir, we then have another tube that goes from the bladder to the outside, and that's called the urethra. It also is lined with a mucous membrane, but it is how the urine exits via the body, or leaves the body. The external opening of the urethra is called the urinary meatus, and that's true for both males and females. The female urethra carries only urine, but the male urethra does transport urine and also semen during ejaculation. So here we have a picture. Oops. Okay. So here we have a picture, and you can see this red artery right here is our aorta, and you can see this little area here is the renal artery that comes off of the aorta, and then it breaks off and branches into a lot of smaller branches, which then goes into this outer layer, which is the cortex, which is where the glomerulus and Bowman's capsule is. So this is where our filtration process takes place. And then you can see these triangles here. This is the peritubular system, okay, with the renal tubules. And then this is where we have secretion and reabsorption of different ions and water. Eventually, that glomerular filtrate will then siphon into this inner area, which is the pelvis area. But before there, we have the minor and major calyces. So we have some cup-like areas that start to collect all the urine, take it into the renal pelvis, which is the very center part of the kidney. And you can see that's what opens into the ureter right here. And then the glomerular filtrate, or the urine, exits the ureter and travels all the way down to the bladder, okay, which is there for storage until it's time to void. Okay, true or false? The core unit of the kidney's filtration system is the nephron. And once again, we talked about that a couple slides before. That is true, okay? Our kidneys, both kidneys, contain millions of these microscopic filtration units that are always constantly secreting a little bit of urine. But that is the nephron is considered the functional unit of the kidney, and it is where the filtration takes place. Okay, so then we have to kind of talk about the different phases of how urine is formed. Okay, and so we have three different processes that lead to urine formation. Okay, we kind of already talked about the first one, where we have glomerular filtration. So the first step in that is the filtration process. Okay, and so as the blood enters through the renal artery, it then branches through a network of smaller and smaller arteries until it gets to a small arteriole, and then it actually reaches that capillary, that ball of capillaries called the glomerulus. Okay. All right, and that point, the blood is pushed through by the pressure from the heart, and that kind of forces the blood through the glomerulus. And then a lot of what's in the glomerulus is not siphoned through, it's reabsorbed into the bloodstream. But what does go through are things like water, sugar, salts, nitrogenous wastes like urea and creatinine and uric acid. Those are byproducts of protein metabolism. So whenever we eat protein or break down protein, those are the byproducts. Those particular waste products are toxic to the body. And so if we don't get rid of those byproducts, it can become toxic. We can form something called uremia, which is where these byproducts get too high in the blood, and that can actually cause death. And so that's why the kidneys and the process of filtration is so important. Okay. Then after we have that filtration process where we get some of those ions and water and even sugar sifts through the glomerulus, we have the next step in there is reabsorption. And so a lot of things in that first part of the tubular system are actually reabsorbed. The primary one is sugar. Generally, if our sugar level is normal, 65 to 100, then all of the sugar will be reabsorbed in that first part of the proximal tubule. If someone has diabetes and their sugar level is really, really high, let's say 200 or 300, then what will happen is that that tubular system, proximal tubule, will not have the capacity to be able to absorb all of that sugar, and then it starts spilling sugar into the urine, and that's a situation where we have something called glycosuria. Okay, and then as that filtrate travels a little farther, we actually have areas in the peritubular system where we can also secrete. So this is where our body can reabsorb water if necessary. If we're dehydrated or if we need to get rid of water, we can secrete hydrogen ion or sodium ions to have water follow. If our body is too acidic, then we can get rid of hydrogen ions. And so our body can balance our pH system here through this reabsorption and secretion. situation, as well as help us with dehydration, or if we have too much water in our system, too much fluid, we can get rid of water and sodium to help balance that as well. So this tubular system allows us to keep not only our pH, but also our salt and water balance in check. Now, when we actually look at urine, urine consists of a number of different solutes, like we talked about, as well as water. But the thing that's amazing to imagine is that we have more than 40 gallons of blood that are actually siphoned, that actually go through the glomerulus. I think the book says 180 liters. But only 1% of that is actually eventually formed into the glomerular filtrate, okay? And so only 1% of everything that goes through these kidneys is actually siphoned through into filtrate and then released as urine, okay? And the normal urine output for an individual is about 1.5 liters per day. Once again, that will vary depending on how much you drink. That's about 1,100 to 1,300 mils a day, okay? And so true or false, as we discussed in the text, the formation of urine begins in the glomerulus, and that is true. And once again, only 1% of actually starts as filtrate is excreted as urine. Okay, so something else we need to discuss too is sort of the normal characteristics of urine. In urine, you know, interestingly enough, we can see a lot what's going on with an individual from just during a urinalysis or a urine dipstick. And so what we'll go through here is just kind of talk about some of the normal characteristics of urine, and then some terms that are actually can define when we actually have abnormal constituents within the urine. So the first thing we do is we kind of analyze a physical inspection. And so first of all, we look at color. And so the color of urine can vary. It can be anywhere from extremely pale yellow to sort of a deep golden or amber color. And that will depend primarily on how much water is being drank. If somebody drinks tons of coffee, it's going to be a darker color. If somebody drinks a lot of water, it'll be more pale, okay? And so when we have darker urine, that does tend to indicate a greater concentration of solutes, okay, or less water content, okay? Then we can look at the clarity. That's another physical inspection, okay? Normally, urine is clear. When we start seeing a cloudy or turbid, those two words are kind of synonymous to the urine, it can indicate that perhaps there is infection, because that cloudiness or turbidity can indicate pus or the presence of bacteria, okay, or some form of an infection. Now, if urine stands for too long, if it sits for more than about an hour, it will start to form precipitates that don't necessarily mean that there's infection. So that's why making sure that if you're going to do an analysis on urine, that you do it within the first hour of the void. If you're going to be beyond that, then generally we will store it in the refrigerator, and it can be stored in the refrigerator for up to 24 hours, but you must take it out and return it to room temperature before you start doing analysis on it, okay? So the thing from that is that it can start to change and precipitate and get a little cloudy with time if you leave it sitting out for a prolonged period of time. Now, that's something else to recognize too is odor. Urine can have a little bit of an aromatic smell to it, but it's generally not too unagreeable, okay? It's not a horrible smell. Sometimes when people are starting to notice the onset of an infection, which can indicate bacteria and pus, then sometimes the odor will change a little, become a little bit more malodorous. You can also notice, you know, certain things if people eat certain foods, certain antibiotics, certain vitamins can kind of change the odor of the urine as well. Normally, we don't really note it. It's more of a secondary thing, but sometimes people will note that if, you know, they're having an infection. Then we have something called specific gravity, and the specific gravity is kind of measuring the amount of solids or solutes within the urine as compared to distilled water. And so the normal specific gravity that urine has is somewhere between, this says 1.003, but it's actually 1.005 to 1.030. And what those numbers mean is just the higher the number, the more the solute compared to water. And so water has a specific gravity of 1.000. So when you add solutes to that, depending on how many, the number will get higher. Sometimes when we have an infection, we'll notice that the specific gravity goes up as well. And that's because the pus and the white blood cells can take the place of a solute and cause the specific gravity to go up. Then we could also look at pH, and pH is called the potential of hydrogen ions, and this measures either the acidity or the alkalinity of urine, okay? And a pH of 7 is considered completely neutral. That's what we find within pretty much our blood for the most part, our cytoplasm within the cells, kind of rests along that, or sits along that line. Anything below 7 is considered acidic, and anything above 7 is considered alkalinic or basic. And so the urine pH can vary depending on what you're eating and other conditions that are going on within the system. So the average can be anywhere from about 4.5 or 5 to about 8. Generally, you can find that if you start getting more of an alkalinic urine, that sometimes can indicate that there's an infection as well as some other disease processes. And there's some other things that we check for in the urine too. One of the first things is protein. And so we can have very microscopic or trace amounts of protein in the urine, but when we do the reagent dipstick or strip in the urine, generally it shouldn't turn colors. If we start noticing that there's protein in the urine, then that can indicate either infection or some sort of disease process with the kidneys. And so trace amounts can be normal, but higher amounts can indicate that the kidneys are spilling a protein called albumin, which is one of our plasma proteins within the blood. And if we start getting those proteins in the urine, then that can be problematic. And that's a condition called proteinuria or albuminuria. Then glucose, like I mentioned before, normally the urine's not going to have any glucose. If our glucose is within normal limits, which is about 65 to 100, then the proximal renal tubule will be able to absorb all of the glucose that gets through the kidneys, and it does get through the glomerular into the filtrate, but that first proximal tubule reabsorbs all of it, unless it's really high. And so when we start getting levels over 100, then we might start seeing that glucose, then that tube can't absorb all of it, and it will start spilling into the urine. And then we will get a condition called glycosuria, and that is one of the things that happens with diabetics, and one of the reasons why we check pregnant patients with a glucose dip strip when they're pregnant, because that can give some possible clues into an individual that might be developing diabetes or gestational diabetes. Then we have another component called ketones, and normally there are no ketones within the urine. However, if we have a process in our system going on where we actually start metabolizing fat instead of glucose, then that will cause protein or the ketones to show in the urine. And so conditions where this will happen are an individual that's running a high fever, an individual that's having vomiting or diarrhea, or having some state of dehydration. So those are things that can cause ketones to occur, but the other disease process that we look at that's significant for is diabetes. When individuals are in a situation where they either aren't making sugar or they're not processing the sugar, it can then cause them to start breaking down fat. And so ketones can then show up in the urine, and that can be problematic because these ketones are acidic. And when it starts creating an acidic environment within our blood, that can cause problems within our acid-base balance. So question, which substance, if noted in urine, indicates a breakdown of fats? Well, it just so happens we talked about that. And so if we break down fat, then we will get ketones within the urine, okay? The other things, if we have proteinuria, that would be if our kidneys were disease processed and secreting the kidneys. Glycose in the urine would be if we were having diabetes. Blood can happen for a number of different purposes. It could happen because of an infection. It could be from disease from the kidney. It could be from kidney stones. So blood can occur as well. Okay, so let's go through a couple of the terms that kind of involve signs and symptoms with the urinary system. So I mentioned this already, but when we actually have protein in the urine, generally it will be a large amount if it's going to show up on one of the dipsticks, reagent dipsticks. And so albuminuria is also called proteinuria, but it's more specifically albuminuria because albumin is the plasma protein that tends to sift through and siphon through when there's disease processes. Okay. The term anuria, URIA, is referring to a urine condition. So if we have a case scenario where we have urine production that is extremely limited, or a urinary output of less than 100 milliliters a day, that is considered anuria. So although there is a little bit, it is considered little to none. When we normally produce about 1.3 liters, that is considered anuria. Bacteriuria is the presence of bacteria in the urine. Now normally, if you have a healthy kidney and there's no infection, there isn't going to be bacteria in the urine. The only bacteria that might creep into the urine is an external contamination from the external skin as urine passes through. If you have no infection in your bladder, then you shouldn't. If you had sterile, the urine is considered sterile. If you do a catheterization and it's done correctly, then there shouldn't be any bacteria there. But if we have an infection in the bladder or the kidney or the urinary tract, then it can cause a condition called bacteriuria. Dysuria, you're going to see that uria is probably the most common suffix that we're going to deal with here, URIA. So we're going to see that, and that means a urinary condition. And so when we have dysuria, dys means bad, disordered, or painful. In this condition, in this particular case, when we're dealing with urinary condition, dysuria means painful urination, and that's a common sign or symptom when you have a bladder infection. If you had an external yeast infection on the skin, it can also cause dysuria, but it's a common sign or symptom that goes along with a bladder infection. The term enuresis is basically a pediatric term. When children have a certain time frame, 6 months to a year, where they've actually been potty trained, and this is more talking about nighttime control of urine. If something happens and they suddenly start to wet the bed at night, and they've had a period of time of 6 months to a year where they've been dry, then they term it enuresis. And so it's sort of an incontinence of children. It can often be associated with stressful situations, and so, or even an infection. Sometimes that can be the first sign that, especially with females, if they have an infection. But enuresis is a pediatric term referring to bedwetting. Okay. Then we have a couple of terms that are kind of similar. We have the word fatigue, and then lethargy and malaise. And those are all kind of similar terms. Fatigue is sort of a state of exhaustion or loss of strength and endurance. And so it can be a sign of something that's like an underlying physical cause, okay, where you say I'm really fatigued, or you're just exhausted and tired beyond what's normal. I'm going to jump ahead to the other two just because they're similar. Lethargy is sort of a sluggish state or apathetic. So fatigue is exhaustion, but lethargy is just sort of lazy and sluggish, okay? But sometimes you can get a lethargy with some of these disease processes. And then malaise is sort of a feeling of weakness, and that can also be an indicative sign of a disease or infection. So these terms are very similar, but if you can find a synonym that's related to it, malaise is more weakness, lethargy is sluggish or apathetic, and fatigue is exhaustion. Okay. Then we look at a couple of other terms. Frequency is a term where we're having voiding episodes that are more frequent, but not necessarily changing the amount of urine production that we have. Okay, so when someone has a bladder infection, the stretching of the bladder causes it to get irritated, and so it kind of gives women the sensation, or a man, but it's more common in females, the sensation to go to the bathroom more frequently. And sometimes you can feel like you have to go to the bathroom every 5 or 10 minutes when you have a bladder infection. So a key with this word is increase intervals of urination without increasing the daily volume or output. Okay, and that reduced bladder capacity is usually from inflammation or infection. There can be other situations associated with that, but it's oftentimes referred to with infection. We've talked about glycosuria. That's a condition where we have diabetes and we have an abnormal presence of sugar in the urine. Then we have hematuria, which is the abnormal presence of blood in the urine. And I mentioned that a little earlier. That can be a sign of infection. It could also be a sign of bladder cancer. It could be a kidney stone. It could even be some contamination from menstruation. So there can be a number of different reasons why hematuria occurs. That particular pad on the reagent dipstick is very sensitive as well. And so that has to be taken a look at. So that's why we usually will do a microscopic exam as well as that dip reagent pad, because if the dip reagent pad shows that there's some blood there, but microscopically we don't see any, then generally it's a false positive. We talked about ketonuria. That's the abnormal presence of ketone bodies in the urine. Nocturia, noct means nighttime. And so this is sort of an excessive urination at night. You can also, nicto also means nighttime. So sometimes you'll see it nicturia, but most of the time they use the word nocturia. This is just an excessive nighttime urination. Sometimes women will get this. There's certain kinds of incontinence that will cause nocturia. If men have prostate issues and there's pressure on the ureter, that can, on the urethra, I'm sorry, not the ureter, the urethra, that can cause nocturia. Or if someone drinks a ton of liquid before they go to bed, that can cause nocturia as well. Then we have another term, oliguria. Oligo is a prefix meaning scanty. In this case, it means scanty urine output. So it's less than normal, but it's not anuria, where you have little to none. And so this is usually between 100 milliliters and maybe 300 milliliters of urine production. So it's less than normal, but not completely void, not null of any urine production at all. Then we have the term polydipsia. Poly means excessive or much, and dipso means thirst. And so that polydipsia is a symptom we oftentimes see with diabetics because they urinate a lot. That excessive sugar loss through the urine causes water to follow, and so diabetics have the risk of becoming dehydrated. And as a sign of that, they can also have excessive thirst. And then we have the other two that go along. There's the 3 P's of diabetes: polydipsia, polyuria, and polyphagia, which is not here. And so polyuria is the excretion of abnormally large amounts of urine. And once again, that can happen with diabetics because the glucose levels are elevated. That elevated glucose level causes more water to follow, which then does increase the amount of urine that's actually produced. And so diabetics tend to produce more. The problem with that is they tend to get dehydrated, so that's a problem. Pyuria indicates pus in the urine, and that's usually a sign of infection in the urinary tract or in the kidney as well. Urgency is sort of a feeling of need to void immediately. And so that's sort of that urgency, like I've got to go right now or I'm going to pee my pants. And there are some, that particular term can accompany a bladder infection. Frequency, urgency, and dysuria are the kind of the common triad of symptoms for a bladder infection. Doesn't have to have all 3, but that's kind of telltale sign of an infection. There are forms of incontinence called urge incontinence, where irritation gets on the inside. It's sort of inflammation and irritation on the inside of the bladder, but not necessarily infection. And there are some women that will have urge incontinence symptoms where they have to go immediately. Luckily, we do have medications to help treat that, but it is important to discern urge incontinence from a bladder infection. We don't want to give antibiotics if we don't need it. True or false? Frequency, urgency, and bacteriuria are common symptoms of a kidney infection. Okay, now we talked about frequency and urgency, and that is definitely true. And bacteriuria also follows both urinary tract infections and kidney infections. However, bacteria is not necessarily a symptom. It's sort of what happens from that particular infection. Okay, when you have a bladder infection, you're going to have frequency and urgency. Oftentimes, if it's there, it's that's the symptoms are localized to the bladder. When we have an infection that travels to the kidneys, which is a risk, if you don't treat that bladder infection or that cystitis, then the bacteria can travel to the kidneys and cause a pyelonephritis. And that is definitely more dangerous than a bladder infection. Prototypically, those patients will start having upper back pain, nausea, vomiting, fatigue, as well as fever, and that can be more dangerous. Okay, so for now I'm going to stop here, and then I will pick up and do another second half that talks about the pathologic conditions. Okay, so I'm signing out, and we'll check in with the next lecture.